Welcome to Embracing Our Community. Your presence today is greatly appreciated and vital. Your passion and participation make our community stronger. In Los Angeles and across our country, Black women, regardless of their socioeconomic status, are significantly more at risk during childbirth than their white peers. This is abjectly wrong, it's heartbreaking, and it must be addressed. Cedars Sinai is deeply committed to health equity, and we are invested in supporting and elevating Black maternal health. As we listen and learn, we are called to hold ourselves to the highest standards of cultural sensitivity, competency, and compassionate care. Strong alliances with dynamic community partners are vital to advancing the conversation and achieving meaningful change in this space. And that is what tonight is about. Dr. Christina Harris is Cedars Sinai's Chief Health Equity Officer and one of our organizational vice presidents. She has assembled a panel of gifted leaders from California Black Women's Health Project, Morehouse School of Medicine, and Cedars Sinai. Life-threatening problems need courageous innovators, and we have them with us today. So let's begin. It's my privilege to thank you again for your presence and to welcome my colleague and friend, Dr. Harris.
Thank you. Thank you so much, Tom. As the Chief Health Equity Officer here at Cedars, I am really honored to welcome you to Embracing Our Community Live. I'm humbled to be hosting tonight's panel as we come together as doctors and healthcare leaders committed to advancing equity in the Black birthing experience and space and outcomes. The inequities around Black maternal health in America are critical for us to keep at the forefront of our work. This issue embodies every challenge we face in healthcare today, from inequitable access to timely and high quality care, to disparate treatments and outcomes. Black birthing people continue to feel the impact of structural racism and discrimination. Public health authorities and news media and many others have focused national attention on this persistent and troubling issue of Black maternal mortality and morbidity, revealing inequities that affect Black women regardless of their level of education, socioeconomic status, and sometimes even level of health prior to becoming pregnant. Just last week, we learned that Olympic sprinter Tori Bowie tragically died from childbirth complications. We are here tonight to shine further light on these most critical issues. Today in the United States, Black women are 3 times more likely to die from pregnancy-related causes compared to white women. And this is a statistic that perhaps feels the most unfair because every pregnant person should receive the level of health care that supports their ability for themselves and their child to thrive. So we come together this evening as a community of concerned and activated leaders from across the country to examine the state of Black maternal health today and think about ways that we can improve it in the future. So let's meet our lineup of experts. Sonia Young Adam is the CEO of the California Black Women's Health Project based in Inglewood, California. Thank you. Dr. Kimberly Gregory is the director of the Division of Maternal Fetal Medicine and professor of obstetrics and gynecology here at Cedars Sinai in Los Angeles. Dr. Natalie Hernandez is executive director of the Center for Maternal Health Equity at the Morehouse School of Medicine in Atlanta, Georgia. And lastly, Dr. Sarah J. Kilpatrick is the Helping Hand of Los Angeles, chair of obstetrics and gynecology, the associate dean of faculty development, and a professor of OBGYN here at Cedars Sinai. Thank you all for joining us today for our Embracing Our Community Live. So for our audience, we will be saving time at the end of the discussion for questions that you might have. If you're watching on cedar-sinai.live, please enter your questions in the Q&A box of your screen. If you're watching our live stream via our Incomparable Partners, blackdoctor.org's Facebook page, please enter your questions into the comments, and we will promise you we will try to get to as many as possible. And as for our lovely panelists, we want this to be a conversation. Please feel free to jump into any questions that you want to chime in on. And yes, this might mean that we might be talking over each other, but so be it. That's how important this is. And we want this to be a real talk conversation. So let's jump right in. And I'll pose this to Dr. Hernandez to start. So a recent report issued by the WHO, or the World Health Organization, that was recently covered a couple months back in the New York Times, said that compared to other wealthy industrialized nations, the United States has the highest maternal mortality rate at 23.8 per 1,000 women, and that this risk is almost 3 times, as we had stated beforehand, 3 times higher for Black women. Why? Why is this happening?
Thank you so much for that question, Dr. Harris. So this has been happening for a long time. We've seen inequities in perinatal outcomes that have been occurring over the last 100 years. And unfortunately, we saw last year that it increased, and we knew and we had expected a lot of it would be related to COVID-19. So we know that there are some deaths that increased that, that where COVID-19 increased those deaths. But associated with COVID-19 was just limited support and access to support that Black women and birthing people had access to, limited access to care. People were afraid, people didn't know where to access resources. We also know a lot about the structural determinants of health, where we work, live, pray, play, contribute to a lot of the inequities that we see, or the resources that people need access to. We know that adverse childhood experiences, trauma, weathering of bodies, and stress contribute to these maternal mortality rates. And a lot of that is actually related, in particular for Black and Brown populations, to this racism, whether it's structural, institutional. We know that that's at the crux of what's happening around the Black maternal health crisis. And then you have a lot of the isms, and these isms that intersect, like classism and sexism. All of these intersect to create more inequities that are occurring within our population. Racism is a fundamental factor and profoundly influences a lot of what I mentioned with the structural and social determinants of health, whether directly or indirectly. And, lastly, I would just say is that we just have to listen to our patients. We've at Morehouse School of Medicine have done so much research where we ask people and we really center people's lived experiences to see what do they believe is happening. And we did a story collection of 90 stories from women across the country who almost died. And they said the number one thing that happened was that people weren't listening to them. And so that's something that we know is profound and really rooted in a lot of what we're seeing with the maternal mortality crisis today.
Yeah.
But can I dovetail off of that? Because I think
Please
that
do.
what's happening is a lot of the symptoms that women have are considered typical pregnancy symptoms, when in fact some of them are also common symptoms of pretty significant morbidity or mortality. And we sort of, as physicians, need to learn to listen to and try to understand the differences. Over time, the incidence of chronic diseases has gone up, and that is largely contributed by the fact of the social determinants of health. But diabetes has gone up, hypertension has gone up, obesity has gone up, and all of those play a part in increasing the complications related to preeclampsia. It increases the risk of cesarean, and we know that cesarean increases the risk from bleeding disorders or hemorrhage. So all of those are collectively contributing to the fact that Black women have higher rates of those conditions is clinically contributing to the increased morbidity and mortality that we're seeing.
Yeah, in that same article, they point out that the United States is the only, high resource country where the rates of maternal mortality are going up, right? And that is saying something. Like we're not used to being on the leading edge of terrible statistics such as that. I know when we think about health inequities and health disparities, it is not uncommon for education or higher socioeconomic status to be protective of bad outcomes, right? So we know that the more educated you are, or maybe the more income you have, often the lower rates of, morbidity or mortality. But that is not the case in this instance. And in fact, when you compare highly educated women, the most educated Black women compared to white women, I think those rates were like on the order of 5 times more likely. That was astounding. Can anyone speak to that?
Well, I'll
Yeah,
make a
sure.
comment.
Go ahead.
What most astounding about that is that just really emphasizes what we just talked about, which is the lifelong impact on living in a culture that has systemic racism and other aspects of racism through your entire life. So even if you have resources, and we can take Serena Williams as a perfect example, she didn't die, but she very nearly did. Everybody would agree she has plenty of resources and should be getting the best possible care. But she still is a Black woman who's lived in the United States for her whole life. And so that impact of that long-term stress impact is a huge issue in terms of predisposing women of color for a higher risk of poor health outcomes, not just maternal mortality.
Mhm.
Well, can I add, please, that I listened very closely to what Dr. Gregory said, and as physicians, you're seeing a patient before you, and if you have determined, or certainly have the preconceived idea that this patient is experiencing these comorbidities, then where does that factor into the care? So, I mean, we know that there's, the root causes of long-term structural systemic problems. I mean, we know that this is historical. It's not, something that we're suddenly seeing. It's, something that is more suddenly documented. And now, we're certainly more aware of it. But, as a physician, tending to a patient, I mean, is it possible to ignore that patient's either their medical history? Is it when we're not listening to a patient? I mean, what is that other than as a problem with the system, with the training, with the education, with the bedside manner? I mean, so any patient that walks in with pre-existing conditions, you know, I mean, do we see that they are always at risk of dying in childbirth? I don't know, and I'm not just posing a question back to you, but I'm asking that we consider. I think of Dr. Karen Scott so often, because she always says, pay attention to the failures. Pay attention to the system failures. What is happening on the system side that is not acknowledging, recognizing, paying attention, or focusing on, what you might know, or what you should know is, some pre-existing condition. If you're deeming that is, as a significant factor that contributes to mortality. So it's, I think we have
Thank you,
to
Sonia.
really look
I,
more closely.
No, I think you're 100% right. And I think to some extent, that's what the California Maternal Quality Care Collaborative and the AIM and ACOG bundles are about, right? That if we can standardize care, to some extent, we could take some of those biases or away if we do the same thing to everybody. But of course, you still always have to individualize care. And I try to always remember to remind trainees that woman did not come in at 2 o'clock in the morning just to annoy you, that she came in because there's something wrong, and our job is to figure out what it is. And if everybody approaches every patient that they see in that way, it could go a long way to hopefully changing some of the outcomes that we're seeing.
There definitely are, individual one-on-one issues at play when it comes into Black birthing people. But, in thinking about the causes that we went into in the first question, it's complex, right? And when you really think about how we got here, something is deeply wrong with the way that healthcare, or we are providing healthcare for this population. One of my favorite quotes is, every system is designed to achieve the results it gets. If we are seeing these inequities, that is because our system has created this, right? And if this is a systemic issue, then we need to treat with a systemic solution, right? In addition to the individual. So I asked to all of you, what are some of the structural or systemic changes that really have to happen in healthcare and health delivery, to be able to bend the arc of this terrible curve?
Yeah, I always think about, we're always trying to address it when a woman is pregnant, and we really need to focus on women's health prior to conception, right? I think, we can't solve years of, comorbidities and stress and racism during the perinatal period. Like, things have to happen before that. And then in terms of structural things, I think it's addressing a lot of those structural political factors, including housing, including transportation, food insecurity, the built environment. We have an epidemic of gun violence, that puts a lot of trauma on different birthing communities. We saw things happen with George Floyd, these dual pandemics of COVID-19 and the racial reckoning that really contributed to, a lot of the maternal mental health concerns we also see, which then we saw is one of the leading causes of maternal deaths, right? So again, we're always focused on the physical when we know mental health is one of the leading causes and contributors to maternal death in the US and globally. Ensuring that people have access to care, that's one thing, but ensuring people have quality access to care, that they're paying attention to, that their structural and social determinants of health are being tended to, that there's care coordination, because our healthcare system works in very siloed ways. And it's a very complicated system. I am a woman with a PhD, and I still don't understand the healthcare system. That's how complicated it
But
is.
I have an MD and I don't either. It is really complex.
And
I really don't
expect
understand
people-
how to pay when you have two different insurance
No,
companies.
no, that's a lot. That's too much.
Exactly. So I think that there are a lot of different structural things that we need to do, and then really paying attention. I sit on the state's maternal mortality review committee, and I love how comprehensive and how we're looking at it with the clinical causes, but the non-clinical, but then what are some recommendations we're making? I think people have really great intentions, but working at the individual level, as you mentioned, Dr. Harris, is not going to solve everything, right? Like, these become sort of band-aids. We really need to address systemic policies, things that affect all of our communities. And there are tools, right? There are things that we can advocate for, like the Momnibus Act with its suite of 12 bills that address healthcare, that address the social determinants of health, that address even the effects of climate change that a lot of people often don't think about, that affect the outcomes that we're seeing within our communities.
So I'll make a couple points. We really do need to think about this in two sort of phases, as we just heard. One is sort of the immediate in-hospital experience for the pregnant woman and postpartum woman. And simplistically, I think the healthcare system is focused on that for years. For years, we've had guidelines, et cetera, to make that in-hospital care better. But most deaths are actually postpartum. And we have forgotten about, and we're just now beginning to think about structural changes for better postpartum follow-up. Some of them are immediate postpartum, but some are delayed postpartum, and we've heard a number of those in the news. And so a couple things I think that are helpful, that are structural, would be number one, in addition to reviewing all maternal deaths, all the severe cases, moms who get really sick, we call that severe maternal morbidity, at an institution should be reviewed regularly too. Because if you can pick up things that you could change that might have made that woman's care or outcome better, that would generalize, making the next person less likely to have that outcome and potentially less likely to die. So,
Yes.
and many of those are system issues, not just the care the physician provided, but maybe what's going on with communication between pharmacy and radiology and getting data back, for example. That's a simple example. So those cases should be reviewed as well at the local hospital so they learn about themselves and what could they at their place do better. In addition, this idea of levels of maternal care, which means hospitals identify and are verified as a basic care hospital that can take care of low-risk moms, all the way up to a quaternary care hospital, a level 4, that can take care of the sickest moms. And once that happens, those high-level hospitals that have all the extra people you need reach out to the community and make access to them easy if a patient needs them. Most patients won't need them, but the patient that needs them, you need a phone number, they can reach you and get the patient to your hospital in the middle of the night. And so making that a community effort is, I think, really important in patients understanding the difference in those hospitals. And then the third thing I'll just mention is, and by the way, in terms of those maternal levels of care hospital, the other thing is insurance issues. So when you have to send a very sick mom someplace, it should not matter who's paying for her. She should go to the place that can take care of her, and there shouldn't be a delay or a problem with that. So that's an insurance in California Medi-Cal issue that is really important for us to look at. The last point is what's now being called the 4th trimester. So postpartum, for women to follow up after they have their baby. Make that easy, make it covered. It is more and more covered in California for longer postpartum care, but make that easy. Make her access to get a visit. Maybe it's virtual. Shouldn't have to come. What mom with a newborn baby wants to come back to a clinic to see somebody? Make it virtual, and you could see her in her environment, and you can see how she's doing. You could have her take her home blood pressures, and that would make easy access no matter where she lived relative to where she delivered. And I think that's a new upcoming intervention that's happening in more and more places that would help with providing ongoing care outside of the hospital once she was home.
Can I add to that? That I
Sure.
think
You don't
that
have
we
to
need.
ask, you can just do it.
I think we need to do a better job of social support. You know, there's the 1,000 acts of kindness for pregnant and postpartum people. We've done a good job of telling people what to do if you think you've had a heart attack or what to do if you think you've had a stroke. We need to do a better job of telling people the warning signs postpartum of what to do if you think something's wrong. If you've got a headache or your blood pressure is high or you're bleeding a little bit more than usual. And I think we can learn from the CDC Hear Her campaign. But I think we need to talk about what our symptoms are and make sure that if you have a friend who's recently had a baby, that we help get them to the right place, the right time.
Yeah.
There are a number of medical issues that are treated differently for Black women, for Black people. So when we talk about the care, the levels of care that end up being where the onus is put on the patient, once they leave, how they interact, what they experience, whether they acknowledge that they have certain symptoms or challenges, or how they express those things. I mean, all of those things are really put on the patient, those experiences. I would really like to see focus on what is happening you know in the system at the point where a patient is connecting with a healthcare provider. I mean, if you express that you have concerns and that person is not listening to you, doesn't value you, or doesn't believe you, those are things that can't be overcome. So when we see or we hear the tragic or the traumatic stories of Black women who show up in a medical environment. And it's not just, during the perinatal phase. I mean, we see this, across other experiences. We know that, Black women, for example, we don't have the highest incident rate of breast cancer, yet, our mortality rate from breast cancer, is through the roof. So I mean, this isn't, we can tend to focus on things that really organizations like, ours at California Black Women's Health Project, or other, organizations that are engaged in this work, the onus is put on us and on, Black women to figure out a way to navigate, to circumnavigate, to sort of duck under, to try to get into a system and make it out alive. And there's a problem with that because it's the system. It is the place and the space and all the ways that it intersects. And it goes back historically to maybe even the training, that you're receiving in school. It goes back, we already know, in the history of obstetrics and gynecology. And so, where you see the ongoing presence of that history, like sort of alive and well as we enter the healthcare system, that is where we have a problem. So yes, we will spend our time, you know, teaching Black women, doing campaigns and doing public awareness and all of the things that we can to say that let's try to save your life because you are going into, a potentially very dangerous situation. And that is really where the problem lies because, many other cultures are not having to, it's almost like, telling your child, or your teenage son or something. Okay, if you stop by the police, this is what this is unacceptable in healthcare. And it we will work on like sort of dealing with it on this end, but really we have to talk more about
Yeah.
what is happening at the system level. What are those failures and how do we deal with those failures? And that is not something that should exist where we have to actually
Mhm.
to constantly remind hospital systems to address that. The accountability, the measurability, where is that part of the work? And that's what I believe is missing in some of these conversations.
Well, I'd like to make a comment. I really appreciate what you're saying, and it's really, really important. And absolutely the number one thing, and someone already mentioned this, as a healthcare provider or anyone in the healthcare system with any patient is listening. And there's absolutely no doubt that listening has fallen off the number one thing. And there is likely no doubt that listening is less well done in minority minority population. So I do think there's discussion of that now. There's honest discussion that this is something we have to go back to doing. And of course, as everybody knows, there's a California Bill 464 that required implicit bias training for all healthcare workers in hospital settings and clinic settings that deal with pregnant women. And I think that's a step. I mean, I don't think that's the fix, but it is a step and it has been done and it is required. And at Cedars, we've done that plus other trainings. And at least it gets people who aren't already thinking about this beginning to understand what that is and how to acknowledge one's own implicit bias and recognize it when it may be impacting your ability to take care of a patient appropriately. So these are baby steps. I totally agree with you. And we need to keep focusing on the experience of a Black woman coming to a healthcare in all areas, but we're focused on pregnancy, a healthcare environment around her pregnancy, to change it from being a one where you have to tell people that they're entering a dangerous experience and that's so dangerous. And as a maternal fetal medicine doctor who's been taking care of pregnant women for, I don't know, 30 plus years, that makes my heart sink when I hear that, because I don't want it to be like that.
Well-
And, oh, go ahead.
Go ahead, because I can.
No, go. Yeah.
Okay, so I mean, I do always advocate for us to sort of bifurcate the experiences of Black women when we enter into a space. We just have to separate it. When we say, oh, we treat everyone the same, I mean, clearly we don't, because
Yeah.
we know the outcomes. But how do we intentionally design something in the system that is responsive to a Black woman once she enters the environment? And if we know already, that there's data that says that, when a Black doctor, is involved, a Black OBGYN or, even maybe predominantly Black staff, because we know it's not just with, direct delivery, it's along that continuum, where the problem, can, start and move forward. So, where, either, we're increasing diversity in the health professions, we know that that takes a little bit longer, but in the meantime how do we intentionally bifurcate those experiences, and is a hospital system willing to be that bold and to be, that courageous and say, if we have a real problem, let's separate it and be very distinct about how we handle it. I mean, that's really what,
Yeah.
without that, you're not really going to get to the root of this issue, because we haven't. I mean, we're talking about the same thing. Well, we're not
I
talking, because we
agree.
weren't talking about it before, but we're talking about something that, you know, goes back to, really, the earliest of our times here in this country, as Black people. So the racism and the rooted,
Yeah.
issues are not new. But at this point, to separate those experiences so that, we are not, living our lives as potentially statistics. So it's our stories
I
that
agree.
become the trauma and the tragedy, as opposed to talking about like the system failed, you know,
Yeah.
failed
I'm going to put my health
another, Black woman.
Hold on, I'm gonna put my health equity chief hat back on. So I agree. That is where we can't afford to not go there. And thank you so much for raising this. I think it is important. I think for so long, we have not looked at our data to really understand the experience of, the Black woman. And we know it makes a difference. And I think that is universally at Cedars, and also as I talk to other peer institutions, we are starting to really interrogate our data to understand the difference in experiences. And when we see a difference in the data, we believe it. We don't try to explain it away. And we go to the patient to really understand. We lift voices that have not always been heard, whether in our typical avenues that we have set up and designed in the past. We have to figure out a way to do it differently. And yes, education and training and teaching providers what the data shows, data proven differences in communication patterns that happen when there are racially discordant pairing, but we have to look at our data and we have to ask, and we have to be okay with seeing data that we're not happy with and doing something about it.
So to that point, there's a lot of clinical outcomes that we recommend people stratify and look at, and we've been able to do that. So, for example, management of hypertension. We want to get that down within 30 minutes, and if you do that for everybody, then obviously you do that for Black women, and they're going to benefit too. Sonia, I just want to acknowledge that. Amen to everything you've said. It's an added stress to be, a person who's experienced healthcare issues and the challenges of that as a Black woman, and then also be on the inside trying to make sure that we're doing the right thing for everybody all the time. And you asked about systemically, what can we do? And the other thing that we have advocated systemically is it's not just the OBGYNs, it's not just women's health. It has to be the family practice and the internist and the cardiologist and the ED doctor as well. So I'm appreciative of the fact that the Momnibus Act, at least in California, said anyone who's involved with perinatal care had to go through the training. But more than that, even now we're trying to make sure that for the sepsis bundle and the cardiovascular bundle, that both the ED docs and the cardiologist are being trained so that when people come in with symptoms of shortness of breath, we're not always just assuming that it's pneumonia or asthma, that in fact it could be peripartum cardiomyopathy. And so that one of the first questions that you have to ask a woman when she comes in is, has she recently been pregnant? So that you can make sure that that's part of the differential. But this is a long way in coming. I mean, at least OBGYNs are getting comfortable with bundles and thinking about it, but trying to make sure that other specialties are exposed is the next place where we're headed.
Yeah, great.
Sounds promising.
And let me add one thing about data, since Dr. Harris brought it up. So we do at Cedars in our obstetric data, we've been looking at outcomes, different obstetric outcomes by race, ethnicity for years, actually asking ourselves, are we doing as well across the board? And the hypertension example that Dr. Gregory just mentioned, we actually have looked at that, and we found absolutely no disparity between Black women and white women or any other race ethnicity about how rapidly they're being treated. And they're all being consistently, month by month, we get a report, and everybody is being treated over 95% of the time within 30 minutes. And so we're very happy about that. But on another example, which also gets to Dr. Harris's point, we looked at the treatment of low-dose aspirin for the prevention or reduction of preeclampsia, and there's guidelines about who you're supposed to treat. And so a few years ago, Dr. Gregory and her team interrogated our data at Cedars and asked, are we treating all the right women? And we were doing terribly. We were not treating enough women, and we had a huge disparity with under-treating Black women. And being Black is one of the risk factors for increased risk for preeclampsia, plus other things. So they should be treated with low-dose aspirin during pregnancy. So an intervention was devised with Dr. Gregory's team, and it ended up, we had a pop-up on our electronic medical record when someone met the criteria. The doctor sees them, a pop-up says, this woman meets the criteria for risk for preeclampsia. Do you want to treat her with aspirin? And the doctor can say, no, because I already did, or yes, please do it. And as soon as they hit yes, the order is sent. And so we implemented that. We rechecked the data a year or so afterwards, and we completely eliminated the disparity between treatment of Black and white women. And so I say that because we're very proud of that. It's a small thing, but it's a big thing. And we made the computer to help us not make that mistake.
Thank you for that, Sarah. Dr. Kilpatrick. I'm going to ask another question. So the 2023 Black Maternal Health Week, which just occurred in April's theme was Our Bodies Belong to Us, Restoring Black Autonomy and Joy, exclamation points. How do we achieve this? What does this look like for our communities?
I
So
can
I'll,
start.
I'll step in on this. Oh, go ahead, Dr.
No, go
Hernandez. I'll
ahead,
follow you.
Sadia.
Okay. Okay. So, one of the things that I can, certainly say, with pride and excitement about the future is that, the groundswell of information and experiences and stories and interventions and prevention models and things that we see across the nation, and the Black Mamas Matter Alliance and the work that they're doing is so powerful. I mean, and in California, I say from San Diego to Sacramento, where we experience the most of our work at California Black Men's Health Project, we see some awesome, community defined practices and community defined engagements, that are happening to support, more sacred and joyous birth for Black women. And I have great appreciation for the investments, that the state of California has and is making, as well as, the work that, I certainly count Cedars, among, hospital systems, that have opened up, their care to include better integration of community based prevention models and community organizations and community centered, and we call them always by Black women for Black women, centered on our experiences. And so there's that movement, that it's so important. And I know that together it's going to take this active deliberate integration of the system and the community, coming together, to really find that joy. The joy is possible to find. We just know that it can't be done in isolation, and so, to see, this onslaught of excitement and enthusiasm around, uplifting Black birth joy is just very powerful. And
Yeah,
I'm proud of it, and I'm proud of the work that we do at Black Men's Health Project, in partnership with, really, I always say, any and everybody, to support the integration of really community defined practices along with medical models, because that's really for a short term particularly, that is really where we're going to be able to stand in those gaps.
Yeah, I would agree. That's exactly how we function at Morehouse School of Medicine, where all of our models are community informed. We recognize that centering Black women's experiences and that Black women's voices are legitimate sources of data. And that rather than focusing on the deficits of our community, we focus on the strengths. We focus on or hearing stories about what brought joy to Black women in their birthing experience, and bringing that into the care that we provide people, bringing that into the research and how we conduct the research with Black birthing people. I mean, it's, as Sonia mentioned, being in Atlanta, the birthplace of the reproductive justice movement, with a lot of really great organizations, the civil rights movement, all of that. I see this awakening, this, everyone coming together rather than working in silos to say, we've had enough of this. We know how to do this. We have created models prior to what has happened now that have brought us joy, and we're going to bring it back, and we're going to hold people accountable for it. So I think, as Sonia mentioned, there are a lot of different ways we can think about it. But the first thing is making sure that we center Black people, that we co-create tools, that we listen, that we come to consensus of how people want care, and make systems and people accountable for what's not happening, that's not bringing us joy in our birthing experience.
That's right. I think I'm going to try to sneak in one or two more questions before we turn to our audience questions that are coming in. So I know that all of you on the panel have been focused on advancing Black birth equity for many, many years, if not a whole career. And it seems in the past 5 years, there's been a lot more public visibility, which I know we all welcome this attention as it accelerates, I hope, our country's collective response to this very, very long-standing issue. This visibility, rightfully, has Black pregnant women and families wanting to know what they can do to ensure a safe pregnancy and birthing experience. And I know that we have many viewers tonight watching us on our blackdoctor.org partners who may be pregnant or want to know how they can support pregnant people in their life and reduce factors that can contribute to complications or even at its worst, death. And we want to help them try to feel empowered when they're going into this and being able to advocate for themselves and their loved ones as well. Dr. Gregory, what are some of the things that a pregnant person and their family can do to help ensure a safe pregnancy?
That's like a very hard question because it depends on where they are in their life. But I will say that one of the things that I've sort of changed in my mentoring with young people in particular is, we've done a good job of telling people to be, go to college, get your career together, and I think we've lost the importance of family and childbearing and where that fits, and appreciating that there is an ideal time chronologically in terms of your age when you should do that. Now, I'm not saying don't get pregnant when you're older, because I'm a maternal fetal medicine specialist. I'm here to help anybody who gets pregnant. But if you wanted to have an ideal time, to thinking about it younger at the same time that you're planning your career goals, I think that would be, optimizing the age of pregnancy, optimizing your weight at pregnancy, optimizing your health, making sure your blood pressure is under control, your diabetes is under control, your lupus is optimized. Those are some very easy, not easy, but those are some ideal fixes. If you're not exercising, exercise. And I know that that's a structural issue because you've got to be in a safe environment to exercise. So the challenges exist, but to the extent that we can step up and own what we can, we should. And then being around a supportive environment to decrease the stress as much as you can, and have somebody there with you who helps, or, some partner or some life person who can help you.
Anybody else?
Well, I'd like to just make, so I want to make a comment about the pipeline because it's pertinent to that, but I also want to say, I just want to talk about something that everybody on this panel knows, and I'm going to guess that everybody in the listening audience also knows because it's very public, and that we had a tragic event here at Cedars a number of years ago, and we will never forget that. And I can't emphasize that enough. And I just think it's important, and would be disrespectful if I did not mention this on this call, because obviously this is the topic we're discussing today. So I just want you to hear that. I do want to make one comment on pipeline because it's pertinent to an earlier point, and it's pertinent to what we're talking about now about what people can do. And there's absolutely no doubt that women feel more comfortable with providers, physicians, nurses, whatever, who are like them. I mean, it's kind of like a no-brainer. And we have done a terrible job in medicine of making sure that we have a significant number of non-white doctors and medical students. And I think we are very conscious of that and have worked very hard at Cedars in the last number of years. It is a pipeline issue. So you have to get those, we'll just stick with Black at the moment, Black into the medical school. You got to get them out of college into medical school and then into residency programs. And we've made many efforts to change how we identify medical students to interview for programs across departments to increase our percent Black residents. And ideally, those Black residents grow up to be great doctors, as we expect them to be. And ideally, they will want to stay in programs where they did their training. So there's a lot of focus on this because it is ridiculous to have the physician doctor group not be similar to the patient's population they're taking care of. So there's a lot of effort on this right now. And I think as an individual, as a Black woman, if you want a doctor who is Black like you, you should search for that. And unfortunately, there are not enough of them, but we are working on making sure that there are more and more.
Yeah, and I'll add to what Dr. Kilpatrick said about the pipeline, or at Morehouse School of Medicine, we like to call it pathways, right? Where interprofessional education has been at the core of what we've been doing, broadening interprofessional training, even to community-based settings, thinking about Black and Indigenous models of care, including midwifery models of care, along with the inclusion of the social sciences, the humanities, bioethics, and public health. I mean, you see so much strength when you do that. I'm a social behavioral scientist, population health. I work with basic scientists. I work within my own department of obstetrics and gynecology with clinicians. And we see better outcomes when we're working together, when we're learning together, we're demonstrating that than when we practice. And then we also just need to build new accountability measures and mechanisms between educators, researchers, clinicians, and the communities. As I mentioned again, what's central to us at Morehouse School of Medicine is our communities and engaging in this practice of critical institutional and individual self-reflection, but again, with communities at the center of that. And, as others mentioned, you as a patient have the right, if you don't like the way you were treated, you have the right to change your provider. You have the right to birth in a space where you want to birth. You have the right to bring an advocate with you. It can be a community health worker, it can be a doula, it can be a patient navigator, someone who can help activate the power that you already have. We're not here, I love what Dr. Karen Scott says. I know we've been bringing her up, but she's like, we're not here to empower communities because communities have power. We're here to activate the power and provide resources and tools to activate that power that communities already have. And as an individual seeking care, you can do that. You have every right to do that. The way we think about our hair and our nails, and we don't like the way someone did it, is the same way we need to think about who's providing care to us. So I just wanted to give some of those tidbits.
Yeah, I appreciate that.
Dr. Hernandez, wow, I really appreciate, what you said. And I just want to say, I didn't grow up in an environment, where preconception was a thing, where anyone was talking about, what that looks like. And, I mean, I tell some stories and they would probably make you giggle or, ask me some more questions, but, um, you know, I don't necessarily see that very much in our community. And but when we are pregnant, when we are, with child, um, you know, Black communities, or and Black women, we're a tend and befriend kind of people. We support and we uplift one another. And for anyone, seeking to have, a safe and joyous birth and a family experience, we encourage people to, be loud and proud to talk about it. Some of the things that, we're aware of now that are, in the news because of celebrities or because of, the news media, taking more interest in this issue, that has created a little bit of a level of fear. But what it has also done, it has raised an awareness, that you don't have to go into an environment and have an unsafe experience and then wonder, what did I do? Or,
Mhm.
why did that happen to me? You can, rest assured that probably somewhere along the way there's some systemic issue. But we encourage, our community, to embrace the birth worker community that's out there serving doulas and midwives. And I even advocate strongly for expanding the scope of practices of our birth workers to be able to spend a great deal more time. And so a birthing person never has to go alone, never has to face an experience without the support and the level of care that's direct and that's culturally rich and that's rooted in our African and our African American history and heritage. We at Black Women's Health Project, we utilize the sister circle model of engagement. So much of what we do around training and engagement is done through sister circles, and bringing birthing people together in spaces where they are loved and cared on. And we call it Showering the Village, is a program that has been developed here by our director of maternal health, Raina Granberry. But showering the village and bringing all of the family members in, bringing the whole village, whether they are blood relatives or not, and showering that village with knowledge and supportive services, and with wraparound care, and with um, things that they can utilize with knowledge and understanding, so that the onus isn't just on the mother or the person giving birth, that it's the onus is on the whole family to
Mhm.
to love and to uplift that that potential joyous birth that we all strive for. So
That's wonderful. I love that. I think we all know community is everything. Like community, and it's gotten, it's gotten me through so many different things. It gets, and it will continue to, because that collective circle is necessary when we're up against what we're up against. Okay, so I'm going to turn to some questions from the audience. Again, if you want to ask a question to one of our panelists, please use the Q&A box if you're on the Cedars .live site, or on the comment section for the blackdoctor.org live stream. I'm going to start with one for Sonia. So my daughter, because it kind of dovetails on what you were talking about, my daughter is pregnant, and I want to help be her advocate. What are some questions or keywords that I should be asking at her doctor's appointments, so she can be best prepared for this?
One of the key words that I always suggest is slow down. I
Oh,
always tell people, tell your doctor, your medical professional, to slow down and to repeat that. And can you say that again?
mhm.
I also encourage people to ask the questions about the steps in the process. I mean, we tend not to receive information about, and then what happens next, and then what's next, and then what's next. It's like, what are the steps in the process that that they're going to go through, and as they see the next physician, and what should they be doing next, and take notes. And even the fact that this person is talking about you know being an advocate. I mean, using that strong voice, using your voice, being a good listener, but also, having, the power and the courage and the empowerment, to ask the question again, and to ensure that you're getting an answer that you understand, and that maybe you can repeat back, and ensure that you are in sync with what the health professional is communicating.
Appreciate that. Thank you. Okay, I'm going to move on to the next. For many reasons, there are patients who want to give birth outside of a hospital or a medical center. What are the role for doulas or promotores when it comes to improving maternal health outcomes in communities of color?
Yeah, I can do that. So, how we do it at Morehouse School of Medicine is we make sure that doulas are there to provide that social support, to be that village for our community members. The community health worker or promotora part is to provide that health education. What are the warning signs? What are things to look out for? What is actually happening with the maternal health crisis? What is respect? How do you earn that? How do you have that relationship with your provider? And then helping them to navigate, again, the complicated system. What are some ways, do you need an appointment? Can we help you make an appointment? Do you need Medicaid? We can help you. I mean, in Georgia, we have a lot of different barriers than y'all have in California. So keep us in prayer. But we're trying to manage that
There's
through
us.
this expansion of this
Mhm.
perinatal workforce. And we have developed a community-based perinatal patient navigation program where we have people with lived experiences from the community who are trained as doulas, who are trained as community health workers, and who are trained as lactation peer support. And we're testing the clinical effectiveness outcomes of this in a safety net setting in Atlanta. But what we've seen through the narratives is that, these are persons who provide those essential services and those linkages to services, who vet the resources, because we can send someone somewhere, but if that is going to be a place where they receive disrespectful care, or it hasn't been vetted in a long time, or doesn't really consider the needs of Black women and their culture specifically, then that's not a really good resource. And so I think there are different roles. Of course, doulas and community health workers need to understand their scope of practice, but they really need to be integrated into clinical care teams. They really need to be integrated in these systems, as well as outside, if people want to choose to give birth outside of the hospital.
Thank you. So I think I'm gonna thank the viewers for their questions. And we've shared some resources on these important topics on the cedars.live, and we'll post them also in the blackdoctor.org. To wrap us up, I want to go through our lovely panelists, and I would like to invite each of you to share your closing thoughts. And maybe also especially where you hope to see improvements in this space. Maybe what makes you hopeful. Let's start from there.
Okay, I'll start then. So I actually want to emphasize, the essential options in public-private community partnerships. I definitely believe, and I know, I think of the AIM work in Los Angeles County African American Infant Maternal Mortality Initiative. That work in LA County, really is a prime example of what that community public-private partnership looks like, and how it is serving in the LA County area and supporting more joyous and sacred births. I also, say at California Black Women's Health Project, we, emphasize educating people. And I know you mentioned about, alternative um, places for birth, but we emphasize at least educating people that they do have choices, that they do have, options for, choosing birth workers, choosing birthing centers, not going alone, being very mindful of the hospital setting, being very attentive. We also, look at, again, this integration of the community defined practices that, I think it was Dr. Hernandez was talking about. And then, in California, I mean, we have made advances. So we have some things that we can be proud of, but there's more work to be done. And as there are, just opportunities, I think about Dana Sherrod. I don't know, if all of you know her. But Dana is the co-founder and a director of the California Coalition of Birth Justice. She had an article or a piece recently where she talked about transformative solidarity. And so that opportunity where the community, everyone is coming together, because, we're talking about a matter of, life and death, at the earliest phase in life. And so I support that kind of solidarity, and I support that solidarity with the healthcare system, with our public health system, with, private individuals and agencies and institutions, and our community coming together to really, potentially solve, this, so that we're not having these conversations in decades to come.
Yeah, thank you.
I'm
Well,
happy to go next.
go ahead, Sarah.
Okay. First of all, I think the community partnerships are, you're absolutely right. That's the number one thing we need to keep working on for sure. But even more concretely, I would say another really key thing is better education, easily accessible education in whatever format works for an individual about preeclampsia and hypertension and the postpartum piece of it, and therefore that connects with what I said earlier about the better postpartum follow-up with all patients, but particularly with patients who have elevated blood pressure during their pregnancy admission. But just helping everybody know what is preeclampsia and what are the symptoms. Their symptoms are relatively simple to describe. Everyone who's thinking about pregnancy and their family members should know what those are. And we, the medical community, should make that easily accessible.
Thank you.
So I would say that, and this is getting back to your question about a joyous birth. I sometimes feel like I give more therapy than clinical advice sometimes because people are so afraid after they've read everything in the newspapers. And what I like to remind people is that women are, and birthing people are put on this earth and they are perfectly designed to do this. And you just have to trust the process because physiologically, this is what you do and what you can do really well. And my hope is sort of echoing Martin Luther King's dream, and that one day it won't matter what color your doctor is, that you're going to get the right care at the right time for your right condition.
Thank you.
Yeah. And just with everyone else, this work is really personal to me. Have had those lived experiences. I've been fortunate to have amazing birthing experiences, but suffered from maternal mental health issues, and so I'm dedicated to this work more than sometimes I, want. But I envision a time where we would have these sacred and joyous births, where we're not having these conversations in the next 5 years, that my daughter, who's a Black girl, will grow up to be a woman who can have an amazing birthing experience wherever she goes in this country. And I want the community and others to know that, we are you, we see you, we hear you, we are you. And don't forget that.
Well, thank you all so much. This has been a wonderful conversation. Transformative solidarity is what I am walking away with, because we owe it to our Black daughters that are coming up. Thank you for our partners at blockdoctor.org, and I appreciate you staying for a couple minutes after the hour with us. Thank you so much to our panelists.
Thank you. Have a
Yes.
great day, everyone.